Hi, everybody, and welcome. My name is Neil Seidman, and I'm the co-chair of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. And we're really happy to present our webinar, How to Help Someone You Love Be Ready for Treatment. And our presenter is Dr. Alec Pollard. Now we're going to be recording the webinar so you can see it again on the ADAA website. And during the webinar, feel free to type in your questions. If you look on the right side of your screen, you should see a Q&A panel. And there's a little field at the bottom of that panel. So you click in that field, and then you can type in your question. Then either hit your Enter key or click the icon. And we'll try to get to as many of your questions as we can at the end of the presentation. But it's a nice idea to type in your question as you think of it. That way we'll be able to hopefully get to it a little bit sooner when we get to the Q&A period. And also keep in mind it's private. Only myself and Dr. Pollard will be able to see your question. So before we get started, I'd like to just say a word or two about ADAA. That's the Anxiety and Depression Association of America. ADAA was started back in 1979, and today it's the leading nonprofit organization in the field of anxiety disorders and depression. Our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, through practice, and through research. And we work to end stigma and get the word out that these conditions are real, serious, and treatable. And I really want you to, I want to invite you to visit the ADAA website. It's a really incredible resource. So it's adaa.org. And one of the things that you can find on the website is a wonderful section called Find a Therapist. And there's just a wealth of information, so it's really worth your time exploring the website. And you can support ADAA by making a charitable donation on the website. So we appreciate that. Okay, so I'm really happy to introduce our presenter. Dr. Pollard is the founder and director of the St. Louis Behavioral Medicine Institute Center for OCD and Anxiety-Related Disorders. He's also a professor of community and family medicine at St. Louis University. Dr. Pollard is the author or co-author of more than 80 publications about anxiety disorders and related topics, including 2 really wonderful self-help books, the Agoraphobia Workbook and Dying of Embarrassment, Help for Social Anxiety and Phobia. And also in this year, 2013, he received the ADAA Member of Distinction Award. So let me turn it over now to Dr. Alec Pollard.
Well, thank you very much, Neil. I just want to echo what a great organization the ADAA is, and really I'm honored to be here tonight to talk on this very important subject. Treatment readiness is a topic that is not fully understood and recognized throughout both the general community, but also among professionals often. We underestimate how important this issue is. So tonight, my audience tonight is the family members and the friends of people who have anxiety or depression. Now, I may have some professionals here in the audience, or I may have some people who actually have the anxiety or depressive disorder. But most of what I'm speaking today about will be for the people who care about someone who has one of these disorders and would like to do something to help. So I'm going to start with good news. It's always good to start with good news, that effective treatments are available. Most of you probably know this for people with anxiety and depression. Most of the people who seek out treatment, receive it, and truly participate in the treatment, they get better. And that's tremendous news. But you probably are guessing that since I said there's good news, there might be some bad news. If you take all the people who don't seek treatment, or seek it but then don't get it for some reason, or don't accept it, or try to do the treatment but don't really participate fully, you take all those people together, that's more people that actually do the treatment right. And that's one of the things we need to address. So that's our bad news. Now, why is it that a lot of people either don't get to treatment, or when they get to it, they don't accept it, or they don't fully participate? There's a lot of reasons. One is just simply lack of awareness. Even today, with all the good work that ADA has done and many other organizations, there's still people who don't realize what they have, what their problem is, or they can't accept it because of the stigma that Neil was talking about. Some people know about their disorder, but they don't have access to it. Our healthcare system still today does not provide open access for all of the treatments for these conditions to everyone in our society. That certainly has been a topic of much debate recently. Maybe they have awareness of it and they have access to it, but there are other barriers. Therapies, whether they be medication or psychotherapy, cost money, even if you have coverage. There's time and effort involved in it, especially on the behavioral therapies where it is a time commitment and effort to put into recovery. So all of those are real reasons. I mean, I realize that I could be considered a dental resistant individual, that I sometimes put off going to my dentist because of the pain or the effort or the time. So even things that are good for us or that we know are helpful for us, we sometimes avoid. And there are realistic reasons to avoid it. But then on top of all those things, we have myths, things that aren't accurate about the treatment, misunderstandings. And so here we have a cartoon that sort of represents this. Some of you may have seen the Larson cartoon. It says, Professor Gallagher and his controversial technique of simultaneously confronting the fear of heights, snakes, and the dark. And this really represents, I think, some of the myths of the therapy for anxiety. For example, here you have the evil professor doing things against the will of the patient, who is locked into this cabinet and being thrust to deal with 3 different fears, and at the highest level of those fears. Well, of course, the therapy isn't anything like this, but this is actually the concept that some people have about therapy. You can understand why some might not pursue it. So if we have some folks out there that maybe aren't aware of their condition or aware of the resources for them, or are reluctant to pursue it, what can family and friends do? So let's start with the individual who is receptive to learning about his or her condition, and we'll start with that person. For that person, it is useful to express concern, for example, your concern about their condition and their suffering, perhaps even your concern for your own welfare, if it's affecting your life. You can offer help, and there's many ways you can help. You can offer to drive them to the doctor's office. You can, if you're financially capable, if finances is an issue, you can offer to help pay for the copay for the treatment. You can provide education. You can gather resources and information about the condition that they have, or about what the treatments are available to help educate them. And in some cases, you can even negotiate with them. You can talk about, I tell you what, if you'll go get help for your treatment, I'll do this for you, or I will help you with this. So there are things that with a receptive person you can do to help move them closer to going after treatment. But you must be careful not to try to do too much, because some people are unreceptive for a variety of reasons, and we're going to talk about that. So let's talk a little bit about how do you approach somebody who's not receptive, either because they deny that they have a problem, or they deny the severity of the problem, or maybe they acknowledge they have a problem but they're reluctant to go get treatment for a whole variety of reasons. Again, we'll talk about what those reasons are. Before you move forward, though, there's some things you need to know. The strategies that work with receptive individuals are often ineffective with those who are not receptive. The very things that you might be tempted to do with someone who's willing to listen, open to feedback, are actually things you shouldn't do with someone who's not receptive. So then out of desperation, we often resort to more aggressive tactics if they're not receptive to what we have to say. And these tactics, at best, don't work and often make things worse, unbeknownst to us. Now, do we have to stop there? No. There's things you can learn about how to deal with someone who is not receptive, either to the idea that they have a mental health problem or that there are treatments that they need to go get. But it helps to know why people are not receptive. And most individuals don't understand this. They have their own misconceptions about why people don't go after treatment. They also need to know what not to do. That's almost as important as knowing what to do, because often we're making things worse by doing things that we shouldn't be doing. And then, of course, to know what can work. You notice I say can work. I say can work. I don't say it does work, because there are some things we cannot control. It's very hard for us to accept that, especially when we see someone we care about suffering. But we do have to accept that we cannot force another individual against their will to participate in treatment. So let's start with some of the reasons why people are not receptive. So I want to introduce you to the concept that we call recovery avoidance. Recovery avoidance. It sounds like a misnomer, doesn't it? Why would anybody avoid recovery? Because recovery is a good thing. Well, let's talk about that. But first, let's understand what it is. It's a pattern of behavior that is inconsistent with what you would think someone would do if they're trying to get better. And the person may not bother to seek help, whereas a family member may be busy looking up information on the person's anxiety disorder or their depression. But the person themselves may not be as interested. If they go to treatment, maybe they don't really fully participate. Maybe they have to be nudged to go. And it seems that everyone else around them working harder than the person who has the problem. This would be a person we would be calling a recovery avoider. So that's recovery avoidance. Now, people have all sorts of ideas about people who are recovery avoiders. And it's natural for family and friends to assume certain things to try to explain their behavior. And we resort to all sorts of notions, mostly pejorative terms. Well, the person's lazy. Why won't he get up and go get help? He's selfish. He doesn't care about the rest of us. He doesn't have willpower, or he's not disciplined enough. He's irresponsible. Maybe he wants to be sick or disabled. Maybe he's just doing this out of spite. There are all sorts of ideas that out of frustration and desperation, family and friends lean on to try to explain the person's behavior. But I want to suggest to you that those concepts about the people you care about are neither accurate nor helpful. They don't tell you what to do. There isn't an anti-lazy pill, even if there was this thing called laziness in this person. There isn't a shot you can take for selfishness. So these concepts are, even if you want to propose that they're true, they're not useful because they don't tell you what to do. And that is the hallmark of what in science we call explanatory excellence. When a concept leads you to an intervention, an action, that can then have an outcome that you want. So here's some things to consider to try to understand recovery avoidance. What really, really does cause it? And to some of you, these may be obvious, but it bears repeating. No one wants to be anxious or depressed or have the life that their anxiety and depression dictates. No one. There is no inner need in anyone to be sick or to be disabled. Now, there are factors that push them in that direction, but there is not an inner need to be that way. Now, this one's very important. The promise of a better life is not always enough. Many people think, well, gosh, it's just the idea of maybe being able to function better, to be able to drive your car wherever you want to go, or to be able to do whatever it is your disorder has kept you from doing, that should be enough. But it's not. We're going to talk about that too. I also want you to know how incredibly common recovery avoidance is. And I want to suggest that each and every one of you has engaged in recovery avoidance. So let me ask you, have you ever had difficulty actually following through with that new diet that you were going to try, or that exercise plan, or that cutting back on smoking or drinking that you were going to do, or not following any of your doctor's recommendations or your dentist's? How many of you floss twice a day? Now, these may seem trivial compared to the recovery avoidance we see in our anxious and depressed relatives and friends. But nonetheless, it is behavior that is incompatible with suggested guidelines for healthy behavior. So it helps us to understand, when we understand that something is actually fairly common, we can be more empathic with that individual. And when we are more empathic, we can be more effective in dealing with that person. So if you understand the forces that actually contribute to recovery avoidance, rather than these made-up things like he's selfish or he's spiteful or he has a need to be sick, if we can eliminate those and really understand what really, truly shapes human behavior, you've got a better shot at being effective with that person. So what are those things? Well, there's misconceptions, as I said before, and sometimes just correcting the misconceptions can do it. So you should see that person be more receptive if they have misconceptions about therapy. However, some others are more powerful. Fear is a huge, huge factor. And even though some people will not acknowledge that they are afraid, it is at the root of many, many people who avoid recovery. The other concept I want you to think about is incentives. Insufficient and competing incentives that will push a person away from pursuing recovery. So we're going to talk about those things a little bit. First, let's talk about fear. Did you know that all fears can be reduced to 4 fundamental fears? No matter what their behavioral expression is and the variety of things that the person avoids, you can nail it down to 4 things. One is physical fear. I'm of death or infirmity, some serious injury. Or psychological fear, I'm going to go insane or lose control. Social fear, the fear of being rejected or abandoned by others. And then spiritual fear, the fear of God's punishment or judgment. That at the heart, beneath all phobias, anxieties, the fundamental fear of one or more of these ultimate catastrophes. Now, why am I telling you that? Because you may not know which of these is driving the behavior of the one person that you love or the person that you're trying to get to treatment. But it's good to be thinking about which of these is driving that fear. Now, fear is in the emotional center of the brain. Most of it is regulated in this part of the brain that is very different than the logical part of the brain. But the most common technique that people use to try to persuade someone out of their fear is the transmission of logic and information to their loved one. Well, they're speaking to the wrong side of the brain. They're speaking logically to that person. Well, of course the bridge is not going to collapse. I don't know why you're afraid of it. Just get in the car and go. It's not going to collapse. I don't know where you get this bridge phobia. No, that bridge hasn't collapsed in 100 years. Blah, blah, blah. Now, the bridge phobic's not hearing that. He's hearing it in his logical brain, but that's not where most of the phobia is regulated. And so that information doesn't compute. And any of you who've tried to talk a loved one out of a fear, you know this is the case. If you find a way to do it, let me know, because we'll be using your technique in our clinic. So fear is a major disincentive for the pursuit of recovery. It isn't that someone doesn't want to get better, but they are afraid of what might happen along the way and what they'd have to contend with. And they believe at some level that whatever that is, it either, in the emotional brain, they believe that it will lead to either death, insanity or loss of control, social abandonment, or God's judgment. Now, let's talk about incentives, because they play a role in this as well. The incentive dilemma is basically this, and it's at the heart of almost every problematic behavior that confronts human beings. All the things that we have trouble changing, whether it's our diet, exercise, drinking, fearful behavior, at the heart is this incentive dilemma. And this is what it is. The reason to do something healthy is delayed, and the reason to do something unhealthy is immediate. Let me say that again. The reason to do the healthy thing is delayed, it's off into the future, and the reason to do the unhealthy thing is immediate. So for example, if I quit smoking, I will someday feel better, save money, be healthier, maybe, hopefully, someday. However, if I quit smoking, I will immediately feel uncomfortable right now. And if you think about fear, for example, phobias, if I in the car and try to drive, I could have a panic attack right now, even though if I do that and I keep doing it, I'll eventually feel better someday and be able to do more things down the road. But right now, it makes me feel really bad. And that's at the heart of the dilemma. So all the promises, the things that we can see, look at all the fruits of you pursuing recovery. They're all down the road. And the person who is avoiding recovery often sees just what's right in front of him or her, which is the discomfort and the pain of trying to move forward. Okay, so that is the incentive dilemma. It is a common dilemma, and as I've mentioned, it's at the heart of all sorts of things that affect many of us. And I dare say the incentive dilemma has been an obstacle in all of our lives at one time or another. And it's hugely operating in the case of a person with recovery avoidance. So if we were to say the simple statement, it seems so simple, but a person will be willing to pursue recovery when the incentive to recover is more powerful than the incentive to avoid recovery. Now, when you read that and you look, you think, well, it's obvious, of course. As my teenage nephew would say, duh. And he says it quite often, by the way, especially to things I say. And you all have been very nice not to do that tonight. Thank you. But even though it's obvious, we don't think of it when we're dealing with someone that we care about and we're motivated to get help. But this is actually at the heart of things. And unless something in that shifts, the pursuit of recovery may not happen. So what do we do when we're frustrated with that family member or we're trying to talk logically to them? We do things that we think make sense to us at the time, and they're pretty normal and natural to do. Nobody has to feel bad about doing these things. There are two tactics I want to talk to you about: accommodating and minimizing. Both are common. Both don't work. Well, by the way, that doesn't stop us from doing them over and over again. Seems to be a human thing. So what is accommodating? You may know it by the word enabling. Accommodating is when we help our, now I'm using here mostly example of anxiety, but it certainly is relevant to depression as well. When we help our loved one not have to deal with things, with triggers for anxiety or depression, or if they have OCD, where we assist them with their compulsions, or provide reassurance, or unconditional financial support. Whatever it is, that helps them escape some of the negative consequences of their decision to not pursue help. Because in our efforts to help them feel better, we are actually taking away the incentive to go get help. Remember that issue of incentive we talked about? So there isn't a message that is not helpful, sort of an implicit message when we accommodate our family members. It says to them, you will not recover, so I must protect you from life's challenges. In this case, the expectation for that individual is too low. And we have now reduced the natural incentive to go get help. What about minimizing? Why do we call it minimizing? We call it minimizing because it is a group of behaviors that, in essence, minimize the severity of the condition. Lecturing, prodding, nagging, yelling, criticizing, threatening, name-calling, shaming, to get the person moving or to do something. These are all acts of desperation. Any of us who have been parents know these strategies well, because they are always the behavior of a desperate person, and nobody is more desperate than parents. They are trying to deal with their kids who won't behave. But nonetheless, whether you are a parent or a family member or friend minimizing someone you care about who is anxious or depressed, they are equally ineffective strategies. And they give the message, you can recover if you just listen to my lecture one more time. You should be able to snap out of this. Well, of course, no such thing is true. The expectations of minimizing are way too high. They're not going to change because you gave them a good lecture or a stern talking to. And all it does is make them more fearful and more defensive, which does not promote the pursuit of recovery. So here we have two really common things that families and friends do with their treatment-reluctant loved ones, and they both don't work, and I would say sometimes make things worse, and yet we do them over and over again. Why do we do that? Because we don't know what else to do. and we're desperate. We want that person we care about to be better, to have a better life, and it's hard to give up on that. Okay, so let's talk about some things that can work. Now, you remember those tactics we talked about that you might use with the receptive person? You can do those again. And after you've done that, there are a few other things you might do. You can talk more about how this person's condition has affected your life. Maybe you haven't talked to him or her seriously or in depth enough. Maybe they don't care that much about their own lives, but they would be touched by how this has negatively impacted yours. What are the things you have to do differently than you normally would because of this person's condition? What are the things, the joys of life you don't get because of it? Or what is the pain in your life you have because of it? Empathy is very, very important. Because when you don't empathize, when you trivialize the person's suffering, they don't think you get it. They don't think you understand. So when you say things like, well, I'm anxious too, but I still go to work. You telling them you don't get it because you don't understand the level of discomfort that they're experiencing. It's like me comparing my occasional stress headaches with that of a chronic migraine headache sufferer. They're not comparable. Support, encourage, and praise efforts to recover, even small efforts. Let them know you appreciate what they're doing if they make any attempt at all. And reduce minimizing and accommodating. Now, how you do that is complicated. And you have to do it at a pace that you are comfortable with. You can't just pull all the stops out. You got to do that gradually, just like we ask our patients to work on their problems gradually. And normalize the rest of the family, if it's a family affair, to try to reduce the impact of the condition on the rest of the family as much as possible. Now, this is not easy. So you may need help doing this. But I want to remind you now that your well-being is important too as a family member. Sometimes families have been so focused on the anxiety or depression sufferer that they've let themselves go. They've ignored their own needs. And they're focusing on things that they can't control, in other words, the sufferer, instead of on the things that they can control, which is what they do and how they take care of themselves. So, as I said, you might need help. You might need to get some consultation yourself. Family members never think about the idea. They'll bring that person who won't go get help. They'll drag them in to see the therapist as if the therapist is going to magically convince him of something the family members haven't been able to do for years. But they won't take themselves in to get counseling about how do I deal with this situation. It never occurs to them to do that. And I want to encourage those of you who are in this situation to consider that. Much more powerful than what you've been doing. But there are obstacles. There may not be therapists or counselors that know about this that are available. There may be financial issues, as we mentioned about anxiety and depressive sufferers. The healthcare system tends to focus on the person with the disorder and ignores the family. That's a very common thing. And even expert therapists often underestimate how much help a family needs. That you can't just send them out with instructions once. They need someone to go back to problem solve as they try to intervene. But of all these obstacles, the number one obstacle is the person, the family member, or the friend themselves. They are their own worst enemy because they have myths about they're stuck on changing the person with the problem, and when they won't go get help, they stay stuck on that. Why? well, you can see some of the myths here. The only way for my life to improve is if the person with OCD gets better. That puts the control of your life onto someone else whose life you don't have control over. It's selfish to get help for myself. Or if I go to get help for myself, I'll jeopardize my efforts at trying to help the person with the OCD. Here we say OCD, but this is true for anxiety or depression. It doesn't. The person with OCD will get upset if I seek help, or I shouldn't have to be the one to change, or I should just be able to cope without this help. I shouldn't need the help. We all know about shoulds. They refer to a world that doesn't exist. In a real world, you seek consultation from people who have resources or expertise that you don't have, and it helps you function better. So if we can see these for the myths they are, then we hope that families will seek resources. There are internet resources, and I'm listing a few here, for people with anxiety, OCD, and depression. There are books and articles, and you can find books for family members on ADAA's website, the International OCD Foundation website, and others. There may be a support group in your area. Some support groups have sections for families, and some people have found help with, even though like Al-Anon, for example, is for people who are married to people who abuse substances, some of the principles are similar for someone who has anxiety and depression but won't get help. And then finally, professional consultation. Going to a counselor and getting consultation for how to deal with someone who is a recovery avoider. Because we recognize that our group got interested in this a number of years ago, and because we recognized that there were far too few resources for families in this situation, we started to develop some counseling services for folks, and actually had a grant to study how to help families in this situation. And because we wanted to reach people outside of St. Louis, we were doing much of the counseling by phone. And so we would be a resource. We would be happy to help folks if they're interested. The only problem with the phone-based consultation, if you can go live with somebody, you can get coverage by your healthcare insurance. If you go by phone, most insurances won't pay for it, so you have to pay out of pocket. But it is an option for those who can do that. So let's just wrap up here a little bit, and then we'll open things up to questions. Normal tactics, the things we do to try to help persuade people who are reluctant to get help, are effective with those who are receptive. But there is a significant portion of people who are anxious or depressed who are not receptive. And those same tactics not only will not work, if you keep persisting in them, they could make things worse. So we need to understand this phenomenon, recovery avoidance. It is not such an unusual thing. It's just that in the hands of someone who's anxious and depressed, it has greater consequences. Whether I floss regularly is not as critical to my life as whether I overcome an anxiety or a depressive disorder. And avoiding anxiety, recovery from anxiety and depression is particularly consequential. There are options for families because in the past they have thought that their only two options were to cajole and nag, try to push the person into treatment, which often caused just greater conflict and family strife, or to just sit and powerlessly wait for that person to change their mind. There is an alternative, and that is for you to learn how to deal more effectively and also how to take care of yourself emotionally so that you're in a better place to deal with that person strategically. That is really, really, really critical. And if you can do that, you can have at least better emotional well-being for yourself and hopefully actually be more influential in getting that person the care they need. So I'll stop there.
Wonderful. Thank you so much, Dr. Pollard. And we already have some questions starting to come in. And everybody, feel free to go ahead and type in your question. We'll get to as many as we can. So our first question is from a mother with a young adult son who's 22, has social anxiety, addiction to marijuana, and also has a severe sleep disorder. And she's asking, how can I get started in getting him some help?
Well, the very first thing, I guess the very first and obvious question is, does he want help? And if you have talked to him, brought this subject up, and he's been receptive, that's a very different situation than if he tells you, no, I don't want to talk about it, or it's not that big a deal, or denies that it's a problem. So if he's receptive, then you use the resources to provide information, to find local resources to help him get to where he needs to get, whether it's the treatment for the social anxiety, or it may be he needs to start with stopping the marijuana first and then working on his social anxiety. But if he's receptive, then it's worth your effort to then get those resources and help get him there. If on the other hand he's not, then you need to talk to someone about how do I deal with a family member who won't get help. How do I do this? And this is not something that I can give you 2 quick tips on. And in fact, for me to give you a couple of quick tips would be to do the very thing that I'm asking all of you not to do, which is to underestimate how hard this is. And that's why getting in with a counselor who can help you work through this and strategize. I can share with you that our very first approach is to reduce the stress on the person, on the family member, and to get them to a point where they are less stressed by the person's disorder. Because if they're not, they can't then go to the next step and do some strategic interventions to try to get that person to help, because they won't do it right. They're too angry, they're too frustrated, they're too emotional, and they won't be consistent and effective in how they do it. This is the hardest thing for family members to accept, that they need to take care of themselves first, get healthier emotionally, less stressed by this, and then start to try to strategically intervene with their family member.
The same person responded and said, well, he did some treatment but stopped because of finances. So it sounds like there's some receptiveness there. But of course, we don't know all the details.
Yes.
Any suggestions for situations where the sufferer has some willingness, but there's a lot of financial stress, maybe not, maybe there's no health insurance in the picture. Any suggestions?
Absolutely. And it may be that you may have to find, you may have to try a series of things until you find the thing that works. There are resources, just like I'm mentioning resources for family members on the internet, there are resources for the anxiety or depression sufferer as well. And also getting a good book, a self-help book, is a good starting point, depending on what the nature of the problem is. And ADAA's bookstore has, by categories, different books listed based on whether it's social anxiety or generalized anxiety or OCD or depression. So finding a book and beginning to read and educate yourself about it is fairly inexpensive. If you go past that, excuse me, you can try to find, and I will not kid you that and try to say this is an easy process, but you can try to find low-cost or free services, in particular, talking now therapy, and places to find those sometimes are training clinics for psychologists or other mental health disciplines where they have a clinic and they give low-cost care at a sliding scale fee. There are centers in most every major community where there is low-cost therapy available. Now, here's the key. They don't necessarily know the treatments for the state-of-the-art evidence-based treatments. So you do need to ask about, you get knowledgeable about whatever your condition is. If it's social anxiety, you need to know that the treatment for social anxiety, the primary treatment is cognitive behavioral treatment and specific procedures for social anxiety. And when you get knowledgeable about that, then you talk to a therapist, you grill them about it. You can figure out whether they know what they're doing, but you have to educate yourself or your loved one, and then find the resources. So it's not easy, but there are some options for folks.
And here's a really interesting question. I think I'm just going to read it. What about someone who seems receptive, but thinks they need to understand everything in their past first that made them the way they are? And then she goes on to say, I'm more interested in behavior therapy, but I feel people sometimes stay with just trying to figure out, why did this happen to me? But can that really be preventing people from getting the help they need?
Oh, absolutely. The desire to figure out is actually, figuring out process is actually an official type of compulsion that people with OCD do. I'm not suggesting that I'm diagnosing your family member or friend, whether they have OCD, but the obsession with figuring something out is actually a type of compulsion, an obsessive compulsive disorder, and it's a form of avoidance. It's a great way to not deal with the things you don't want to deal with by chasing the illusion of that you'll figure it out. Now, how do you deal with that with somebody doing that? Because if you try to argue logically about whether he needs to figure it out or not, that's a losing battle. But depending on your relationship with that person, you could ask them, how long are you, since there are these other treatments that have been shown to be effective, like cognitive behavior therapy, for this problem that you have, I understand that you want to figure it out. How long are you willing to try to figure it out before you would be willing to try the therapy, the cognitive behavior therapy? If 5 years from now, for example, you still haven't figured it out and you're still disabled, would you at that point be willing to try CBT? And would it need to be 5 years, 4 years, 2 years? What is it? And see if you can get them to commit to a time period, because they're not thinking about how long this is going to take at the moment they're saying this to you. They're thinking they are delusional with the hope and the promise of that perfect certainty and insight that I will get all of this and then I can move forward. And so you really need to get them to see if they can agree to a time period. And then if you're a friend, hold them to it. So I tell you what, if I don't have this figured out by the end of the year, I'm going to go get CBT. Okay, deal. I'm going to hold you to it.
How is CBT different from just understanding and getting insight about, why did this happen to me?
Well, that's a great, great question. in CBT, it's not that we don't that there isn't a way of understanding what's happened to them. CBT does provide a different way of understanding what's happened, but it doesn't have the kind of it doesn't promise to give you that epiphany, like, oh, now it all becomes clear. And it doesn't promise that once you have that insight, you'll be able to do anything more than what you did before you had the insight. If you have the insight and you don't operationalize it into behavior, it does you no good. So CBT sets up steps and exercises to actually start changing behavior that then changes how you feel. And the illusion that a lot of people have is, I need to change how I feel first, and then I'll change my behavior.
So it's small steps that you get started with CBT.
Exactly.
We got a very nice thank you from the woman that asked that question. Dr. Pollard, you in one of your slides, you were talking about the idea of getting a consultation. And is that something that, say, a family member can propose instead of saying, oh, you've got to get treatment, or I want you to get treatment, to say, well, how about we just go and have one appointment with this therapist that I found?
Oh, absolutely. Now, there's two different kinds of consultations. There'd be one for the anxiety sufferer or depressive sufferer, and then there would be a consultation for the family member if they needed it. So, but that's a very reasonable small step to try to see if they would engage in. They just go and see what they have to say, and go once. I'll give you a ride. That absolutely is a reasonable thing.
Okay. And we have a question that came in asking more about minimizing.
Mm-hmm.
Do you mean minimizing the seriousness of what they're going through? I guess you wanted maybe another example to illustrate.
Sure. Yes, by minimizing, we mean minimizing, yes, the severity of their condition and what it's going to take to change. So if I lecture my brother-in-law, why don't you get out of that chair and go do stuff? Don't you understand? Blah blah blah.
Yeah, like just go face your fear.
Yeah, just go face your fears.
Done.
I do, exactly, exactly.
So that's an example of minimizing.
Absolutely, yeah. And it's saying, yeah, if I just tell you the right thing, something I'm going to say is going to make you change and snap out of this. If you just listen to me. And
Boy, I sure wish that was true. I wish that would work.
Oh my gosh. I would be happily out of business if it was true. And I'd be happy about it.
So it sounds like this connects with what you were talking about empathy.
Yes.
That
yes.
To appreciate the amount of the suffering and to realize that, like you were saying, that, I may have a tension headache now and then, but I need to have some empathy if my loved one has got like this daily chronic severe migraine. Just as an analogy, that having that empathy and not minimizing what they're going through.
Absolutely. And then understanding that that we probably can't possibly know what they're going through at some level because we're not going through it. But we can imagine it if we open ourselves up to it.
And she writes back, she's very bright, she writes back, our questioner, she writes back and she says, well, now, this is somebody with OCD, and this person minimizes the OCD in order to avoid treatment. Like, this isn't really a problem.
Yeah. Now what what she's talking about now is not the family member minimizing
Right,
it, but the person with OCD. Oh, absolutely. Um, and that person will minimize it if you're talking about going to get help, but if there's something that they don't want to do, then they'll tell you why they can't do it. Now, that people with the condition, yes, of course, can minimize as well, and that's part of the problem. They're downplaying it, and that's why us accommodating them. You see, my response to someone is, if you don't have a problem, if you have a problem, you need to get help. And if you don't have a problem, that's great. Then I don't have to do anything differently with you. I don't have to accommodate you in any way or treat you any differently than I would anyone else because you don't have a problem.
Good answer. Excellent. Well, thank you so much, Dr. Pollard. I just enjoyed your presentation so much. I took a lot of notes. I learned a lot. And I want to thank everybody for attending. We hope you got something out of it. And you should be receiving an email that will let you know when the recording of the webinar will be available on the ADAA website. And please let friends and family know about our webinar series. Our next webinar is planned for July 10th at 7 p.m. Eastern. And finally, please consider making a contribution to ADAA on the website so we can continue these kinds of programs and the many other activities of ADAA. So bye for now, and we'll see you next time.